Dumelang, Stanibonani, bonjour. It's wonderful this morning and this afternoon for some of you to host this webinar. Welcome to the State of Data Science in Africa series, which is presented by the National Institutes of Health Common Fund. My name is Mokdad, and I'm here with my colleagues from No Innovation. We are also known as KI, and like the Kai Storm, the KI and Kai Storm, our team based in the US and in Europe and also in Africa facilitates workshops and meetings and online events just like this one to accelerate scientific innovations. And today we just want to start off by giving you a brief agenda for today, and it's right behind me. So first, we're going to start with some welcome remarks with a background on the funding opportunities, and we'll give you a few tips to make the most out of the experience on the webinar today on Zoom. And we'll give you an overview of today's session on using data science for fighting COVID-19 in Africa from our moderator, Stefan. Then a short presentation from each of the panelists that we have today, followed by a Q&A from our panelists. And then we'll have a plenary conclusion at the end. But that's not going to be all. Immediately after the webinar, we invite you to come to the interactive session that we host. This will be optional for you, but we do hope you will choose to join it. And we'll continue the conversation with the panelists and network with others who are interested in the same topic on how data science can help to fight against COVID-19 in Africa. So today's event is associated with the NIH program on harnessing data science for health discovery and innovation in Africa. And I would like to hand over and invite onto the stage Laura Pavlish, the Program Officer of National Institutes of Health at the Fogarty International Center, to tell us more about funding opportunities. And over to you, Laura.
Thanks, Puleng. Just as a reminder, and for anyone who's new to our symposium, today's event is associated with a new NIH Common Fund program on harnessing data science for health discovery and innovation in Africa, or DSI Africa for short. There are 4 different funding opportunities currently open for applications. You can learn more about these at bit.ly/NIH-DSI Africa. Applications are due starting in late November, and we encourage you to visit the KaiStorm platform to learn more about applying to NIH grants. Additionally, the contact information is listed on KaiStorm and in each funding opportunity for each of the appropriate NIH scientific contact, and we encourage you to reach out to us with any questions. I'll hand it back over to Puleng to set up the rest of today's session. Thanks.
Fantastic. Thank you so much, Laura. And if you do hear something interesting and you want to use social media to reach out to the masses who are interested in the same topic, please do use the 3 hashtags on the screen. And those hashtags are hashtag DSI Africa and hashtag NIH Africa Data and hashtag No Innovation. So please remember those 3 hashtags as you go through 2 hours of this session with us today. And before I hand over to our panelists and our wonderful moderator for today, I have a few things that I want to share with you. So yes, we are recording the session today, and we'll post the video on KaiStorm, which is the platform that you've used to get here, and on the NIH YouTube channel. And in both cases, captions will be added. But if you have a technical challenge today, you can always scroll down to the KaiStorm menu, and we have a little page there that says needs help, and we'll be there to sort it out immediately. During the program, we hope you'll add questions for the panelists during the session, and please add those questions by clicking on the Q&A button, the speech clouds on the bottom of your screen. And if you see a question that you think is a good one, you can let us know by upvoting it. We are certainly a very large group today. I see we have over 67 people on the call, and we would like to see, even though there'll be numerous questions, we'll do our best to answer the questions, as many questions as we can get to today. Now, with that, I would like to introduce today's panel moderator, Dr. Stefan Jaeger, staff scientist at the U.S. National Library of Medicine and also at the National Institute of Health. So I hand over to Stefan, Dr. Stefan, who is going to introduce the panelists and tell us more about today. Stefan, over to you.
Thanks for the introduction, Frank. And it's nice to be here today for this very interesting webinar. You see here, the title of the webinar is Using Data Science to Fight COVID-19. We will have 5 talks today that highlight how data science can help in the fight against COVID-19 and the methods being used, giving practical examples. I will be the moderator, introducing the speakers, and I will share my duties with Cecile Viboud. She is from Fogarty International Center, and she will also at the end lead the question and answers, which will be at the end of the webinar. I am a staff scientist at the National Library of Medicine. At the NLM, we are working on machine learning and biomedical image processing, and we have actually worked on COVID-19 to detect it in radiographs like X-rays and CTs. And also we have history in detecting malaria and other infectious diseases like TB. So the topics for today are several. We will look into disease surveillance, measuring disease burdens, generating dashboards, text mining, data interoperability, and also publication tracking. Also, the NLM has actually a webpage, especially for COVID-19 publications, where you can find the latest ones. And but much work has been done on this too. And at the end, we will have 3 breakout sessions with different topics on direct, indirect impacts of COVID-19, and also on the methods and data science being used to fight the disease. This is the latest map of the World Health Organization regarding COVID-19. Africa is actually doing remarkably well compared to other countries like Europe or the United States. Actually, South Africa has 50% of the infections in Africa, and some northern African countries as well. But the rest of Africa actually is doing remarkably well. And maybe we can discuss at the end why this is actually the case, or if data science can help find why this is so. And Africa can, for once, be an inspiration for us, right? And because it's leading now in this. Several reasons why Africa is doing better I've listed here on this slide. It could be the younger population, could be the existing infrastructure that's already in place for other diseases. It could be genetics, the lifestyle, the immune system, better contact tracing. We don't know, but sure, one of these or more of them are really the reason why Africa is doing so well. These are the panelists today that we will have. First, it will be Ali Mokdad from University of Washington, then Agnes Kiragga from Uganda, Makerere University, then Elaine and Nsoesie from Boston University School of Public Health. Then we will have Nirmal Ravi from eHealth Africa. And at the end, we will have Frank Kagoro from, actually, it says he has several affiliations. He is actually with our collaborators at MORU, Oxford Tropical Medical Research Unit, and is also a Ph.D. candidate in Cape Town, South Africa. These will be our breakout sessions. As I mentioned, we will have one of for direct impact of COVID-19 in Africa, one for the indirect impacts, and then methodological advances to monitor and predict COVID-19. You can actually choose one of these at the end or switch between them. We will see how it goes. They should be very engaging. And with this, actually, I will stop sharing my screen and I will introduce our first speaker already. Our first speaker is Ali Mokdad. He is a professor of health metrics sciences at the Institute for Health Metrics and Evaluation, and he's also a chief strategy officer for population health at the University of Washington. As a public health researcher, Dr. Mokdad has published groundbreaking work on local level disease trends and some of the leading risk factors for poor health. And his work on obesity is among the most highly cited in the field. As a director of Middle Eastern initiatives, Dr. Mokdad builds presence in the Middle East through new research projects, dissemination and uptake of methods and results, and consultations with regional leaders in population health. So with this, I actually leave the stage to Ali, and looking forward to your talk.
Good morning, everybody, and thank you for the introduction. I want to talk briefly about IHME model for COVID-19. I will introduce briefly the model, drivers of the model, projection for Africa, some limitation, and how countries can use these estimates. I am from the Institute for Health Metric and Evaluation. We focus on what are the health problems of the world, how well society is addressing them, and how could we maximize our output given the resources that we have. The models at IHME started at the request of the University of Washington Medical Centers. They wanted to know how many beds they need, ICU and ventilators, in order to prepare for the surge for COVID-19 patients coming here in my city where we live in Seattle. And we decided early on to follow mortality because of lack of testing early on, and still in many countries they're not doing enough testing. We felt that death is a more robust metric. And then we tried to always model a peak and see what will happen after that peak, how many ICU beds are needed. And we also used early on mandates. Later on, we have mobility, so I'll show you some data. And then how many infections we will have reported and estimated, and we provide scenarios for health policy in each country. We deal with a lot of problems in the data, and here is an example from UK, England, a country that has a strong health information system and old, historically been one of the pioneers in that. But you could see the data here has problems, especially around the weekend where we have less reporting. All what I'm presenting is available on our web, and just Google IHME COVID-19 and you'll get all these information what I'm presenting today. I'm not going to go into details about the models. I don't have time for 10 minutes, but right now we have a hybrid model, and then we're using in our model to predict future mortality and infection, mask use, cell phone mobility based on cell phone, pneumonia seasonality, which is strongly associated with COVID, testing, population density, particulate matter, smoking, altitude, and of course, pneumonia death rate. And briefly, we take the daily deaths, and you see a lot of noises here in daily deaths. This is cumulative death, daily cases reported, cumulative cases versus cumulative death rates, hospitalization when we have the data, and again, you see how noisy it is. And then we plot hospitalization rate against cumulative mortality rate. And we make sense of all of this data. This is the red line that's projected about the daily deaths. We smooth it, and based on all this information together, we put the three together to get a better estimate of daily deaths in each location. One thing to be reminded that all of us, that in March, every country in the world put some kind of mandates. And the fact that they happen around the same time, it protected some countries because they didn't have enough seeding. So when New York shut down, it was too late in a way because there was so many infections. When a place like Florida shut down in the US, same in Africa, there was less seeding and hence less infections. So the mandate early on helped a lot for many countries. This is in Africa right now, what we see on a daily death. You could see it's around 3,000 right now. It peaked up sometimes towards the end of August. It's coming down. And here is R, effective R in Africa, which is, you could see it, it's clearly, sorry, this is estimated population detected in every country. Of course, South Africa had the most cases so far, so you see it has the highest number here. Daily COVID mortality per 1 million in October 5, still it's very low in Africa, but the highest, of course, as you've heard before, it's coming from South Africa. This is mobility levels in Africa. You could see that's coming back compared to January, almost back to normal, a little bit minus 10%. More so in South Africa. There is a pattern here in the southern part of the continent. You see more, less mobility, and as you will see later, more mask wearing. This is how many people wear a mask. In many places, it's less than 30% in South Africa, and the southern hemisphere of Africa, it's almost over 70%. Detection tests here is very low in Africa, as we know. It's high in some countries, but usually it's very low per 100,000 people. So not much testing going on for early detection of COVID-19. And we present for each country, and of course for the whole continent, which I'm showing you right now, is for Africa. And Africa, and my definition here is WHO Afro region. So the first one is mandate easing, let everything be normal, and then we keep opening for business. Our current projections, which is our preferred scenario, is that we will go into a lockdown when death reaches 8 deaths per day per million per population, and universal mask. If 95% of people wear a mask, what will happen in a country for COVID-19 estimated mortality? So for Africa, between now and now, we're projecting to February 1st, what we're projecting about 700,000 deaths in Africa. Again, Afro region, WHO. If we keep easing the mandates, about 49,000, not much difference here because Africa already has low rate and it's declining. And if everybody in Africa, 95% wear a mask, we estimate that drops to 600,000 deaths. So a huge difference, and a lot of deaths could be prevented simply by wearing a mask. And as you have seen in Africa, it's still very low. The limitation that we have, it's under testing and under reporting of mortality. Of course, we know there are problems, vital registration in many countries that I'm showing. And of course, we don't have in our estimation of bed capacity, we don't account for surge unless the country provides us an updated number about their surge in ICU and their bed capacity. We don't know from the testing how that sample is done, who is being tested. Is it people coming to a hospital, sick people, or is contact tracing? So we have no idea about details, who's been tested. And in many countries, unfortunately, we don't have data, especially daily data about hospitalization. And there are not many surveys in Africa, a few of them about seropositive, how many antibodies have been found, basically to tell us how many people are infected. So in multiple locations, and including Africa, I'm showing you here Delhi and Pakistan, we have seen that the pandemic peaked and come down. And we don't see any association between that rapid decline and mandate. So, you know, the mandate happened early on, as I showed you, then the peak came later on, and now it's coming down. And this, Stefan provided a slide. So there's several explanations. I'm adding one here, role of super spreaders in any country that have been saturated and they're not anymore actively passing the virus to others. But the biggest theory right now that people are zooming on is cross-reactivity to other coronavirus infections. So your T-cell will remember when you see COVID-19, therefore there is less cases or less symptomatic cases in this case, and less deaths, of course, of COVID-19. Of course, we anticipate a large-scale indirect impacts of COVID-19, domestic violence, women's health, child immunization, chronic condition, of course, on education and employment, and we're afraid, of course, all of us, on gender equality, of course, and other type of inequality. Immunization, I'm giving you a slide from MWR here in the US. Even in the US, we have seen a rapid decline in immunization, unfortunately. After COVID-19, starting in March here, you could see in slide clearly that immunization dropped down compared to the previous months. Underreporting excess mortality, we see it in every country. The red here is actual mortality. The other line showing COVID-19 deaths. You could see there is a gap and they're increasing. Excess mortality increases as COVID-19 mortality increase. Recommendation how people use the data for planning, of course, because we provide the hospital, but also mandates a mask with penalty. That's what's working in many places. Also do seropositive surveillance so we can track how many people have been infected, report what's happening in a hospital, and include the surge capacity so we can add it to our forecast, and for every country to be able to know how much your bed capacity is. That's the key issue here. You don't want to overwhelm your medical system, and ICU capacity should be left at least. Don't go above 80%, otherwise there'll be problems because you need these ICUs for other conditions. So, and then don't be afraid to impose a mandate, and then we can model other scenarios for any country. Thank you, everybody.
Thank you, Ali. Very nice talk indeed. A quick reminder for everybody, we will collect all the questions to the end of the webinar, and I answer them all in one session. If you have a specific question, you can enter them in the question and answer box. If you look at the bottom of your Zoom window, there's a chat box and there's also a Q&A box. So please enter these questions in the Q&A box and we will answer them at the end of the webinar before the breakout sessions. Thank you. So the next speaker will be Agnes Kiragga. I will shortly read her short bio here. So Dr. Agnes Kiragga is a senior research scientist and the head of statistics at the Infectious Disease Institute at the College of Health Sciences, Makerere University in Uganda. She was nominated as one of the prestigious Next Einstein Fellows for the year 2019-2020 and featured among the top 20 African innovators by Quartz Africa. Dr. Kiragga spearheads HIV research projects, including the use of routine clinical and administrative databases for prediction of outcomes among persons living with HIV, as well as prevention of HIV acquisition. Her research involves the use of data science methods to address various health challenges in Africa by leveraging the resources at the NIH-funded African Center of Excellence in Bioinformatics and Data Science. Dr. Kiragga supports initiatives for increasing the participation of African women in science, technology, engineering, and mathematics, STEM. So, with these words, Dr. Kiragga, the stage is yours. We are looking forward to your presentation.
Thank you, Stefan. I would like to thank the organizers for giving the opportunity to talk about our experiences in mining social media data, and as well as understanding the indirect effects of COVID-19 on other diseases in Uganda. Yes, so like the previous speakers have mentioned, Africa still suffers from a couple of COVID cases. In Uganda, the first COVID case was identified in late March, and to date we have hit about 10,000 COVID cases that have been identified in Uganda and about 95 deaths so far. The recovery rate is about 63% with very low case fatality rate, and about 12 people per 1,000 people are tested for COVID in the country. So like any other country, there are several non-pharmaceutical measures that have been used to control the spread of COVID. There've been several measures, and right now the country is embarking on measures to combat COVID. We've seen various drives by telecom companies making out deliberate efforts to ensure that the community ensures face masking and, most importantly, physical distancing, as these are important for epidemic control. What we've not really seen is how the community responds to some of these measures and how we can use data science methods to understand what's happening in the perspective of the community regarding COVID control in the country. And so what we decided to do was to look at the social media platforms, and I got this slide that shows that between October 2019 and September 2020, there's been an influx or an increase in the rate of use of certain media platforms. Facebook remains the top media platform that's used in Uganda, However, we see and around April, just after the first case of COVID was identified, there's been a spike in the use of platforms like Twitter. And we hoped to leverage this data to see what is happening in the context of the Ugandan community regarding COVID. Mining of social media data has been done elsewhere. And what we did was to leverage the natural languaging processes techniques to process Twitter information on COVID-19. We picked out tweets or conversations that were available between March 1st to date. And because the activity started quite late, we then went back and purchased historical data of Twitter between March and August 27th, and have continued to stream this data moving forward, with particularly looking at tweets that are geotagged to the coordinates around Uganda. And the hashtags that we've used involve COVID-19, Stay Safe Uganda, COVID-UG, and several other hashtags. We have collected about 100,000 COVID tweets and performed sentiment analysis to understand the positive and negative information around COVID-19 in the country. And what is interesting is that when we looked at this data, we see that most of the tweeting happened over the weekend as expected. People are busy during the week. And this could be a weekend effect because some of the most common words that we see are affiliated to religion or church or prophets, going to church, but most importantly, COVID-19, as expected, becomes one of the most common hashtags that we noticed in the time. We've also seen that as the country goes into political elections, along the way, people start to talk more about elections. And then this slide tells us ideally how the sentiments of people have been evolving over time in relation to the COVID cases. So the red line on the left box, the red line shows the COVID cases increasing exponentially. And on the blue line that is sloping from the left to the right then shows the sentiments of people. So as the cases increase, the Ugandan community, then the sentiments reduce. So we kind of get negative sentiments around COVID as expected. There's fear, there's anxiety, and the same applies when we look at death. With increasing death, the sentiments change over time. People get anxious, people get fearing, and it's important for public health people to see what happens in the community. And then what we also saw is that there are several influencers on the Ugandan Twitter platform. The most common, of course, is the Ministry of Health, which is the top left highest bar on the left on the bar graphs. Ministry of Health has consistently shared data and updates on Twitter. And because of this, it's the most common, it's one of the most influencers on the Twitter platform. And then there've been several other influencers that are very known persons in the community. For example, the second person is a well-known Inspector General of Police, and who eventually got COVID. So just understanding his sentiments along the way when he was going through this COVID epidemic, COVID disease is important. And we also see that with time, most of his sentiments centered around being trustful of the system. And if we have influencers like that, can be very influential in controlling, in informing community how to respond to COVID. And there's much more that we can do with this data. But for now, I'll just stop here. But what is important to know is that mining of Twitter has a great potential to inform public health response to COVID. The community perspective using sentiments is very informative, as healthcare planners and the Ministry of Health in Uganda can then leverage these sentiments or influencers to then inform COVID control. Religious heads and people who are in the spiritual realm can then be used to promote non-pharmaceutical measures for controlling COVID. At a time when churches are being closed for long, it's important to know that we can then use some of these media platforms to inform the public. This data of course, has some biases because it's incomplete for the start. It's based on geolocations, which might miss out tweets in case the users do not have their location turned on. And because of this, there's ongoing work to increase the pipelines and to improve the pipelines for streaming data, to improve its completeness. And again, we want to look at the COVID-19 myths in the Ugandan context and also look at other social media platforms. So I'll then move to the second part of the presentation, which then looks at what has been the situation of COVID-19 and HIV in Uganda. This work is from a recent publication where we predicted the impact of COVID-19 and the potential impact of the public health response on the disease burden in Uganda. That is published in the American Journal of Tropical Medicine. Please check it out if you get some time. So as a brief background, again, like the previous speakers have said, the African continent has experienced fewer COVID cases compared to what was earlier predicted, and compared to other regions and other continents. Africa has about 1.2 million. And again, there are much lower deaths, for example, compared to the US. And like, we think that they are, because of the previous existing infectious diseases and fragile health systems, we thought that the impact of COVID would be much worse. But what is important to know is that there's still limited data on the impact of COVID on other health diseases and looking at the burden of COVID in Africa. So to do this, we then pulled out data that was available at that time, and we leveraged the existing data sets of COVID cases, and most importantly, data on important indicators like the HIV reporting data. But what is important to note is that when we are estimating the burden, we then use DALYs, which are the disability adjusted life years, because these are very useful when you're estimating disease burden, because the age structure of African continent is much lower, which is about 50%. It was very important for us to relate this to the disease burden, and particularly looking at the DALYs lost if a person did not necessarily get COVID, but then suffered from any other illnesses that were as a result or increased as a result of the response towards COVID. We used the WHO Global Burden of Disease estimates, and then looked at the excess HIV that would predict the excess HIV cases that would have occurred in the situation of COVID, and most importantly, look at what happened during the lockdown in Uganda, and we used data that was available at the time when the lockdown had just occurred. And just to give you a brief of what we think was happening, this graph looks at the data from 2019 all the way up to April 2020, when the country had just locked down. And we see a very steep dip around December, which is expected. That's the first dip. But the second dip is at the time when the country had locked down. We see that there was steep reductions in the number of newly identified or diagnosed HIV positive persons, and steep drops in the number of patients who initiated ART at that time. So we use the data as of that time to understand the epidemic. And what is important is that the DALYs that we have, we think that because of the data that was used at the time, the country loses about 405 DALYs due to HIV. And we also saw that HIV mobility and HIV mortality increased to about 465 DALYs lost. And this is a big impact in the country. And we think that this situation has changed over time, because that is the recent COVID, that's the recent data that we have right now. But in conclusion, we think that, that looking at the health service delivery in terms of the COVID response is important, and looking at the long-term and short-term impacts will be critical in understanding the response. I acknowledge my institution and the NIH and the African Centers of Disease. Thank you.
Yeah, thank you very much, Agnes. For the sake of time, we will proceed immediately to the next speaker. Again, please, you can enter your questions in the Q&A box. So our next speaker will be Elaine Nsoesie. She is an assistant professor of global health at Boston University School of Public Health. She has a Ph.D. in computational epidemiology, a master's in statistics, and bachelor in mathematics. Her research is focused on the use of digital data and technology to improve health in communities globally. Her work has also focused on addressing bias in digital data and understanding factors influencing disparities in health outcomes. She is on the advisory boards of Data Science Africa and Data Science Nigeria. She's also the founder of REPE, if I pronounce this correctly, an initiative focused on providing scientific writing tools and resources to student communities in Africa in order to increase representation in scientific publications. Elaine, please go ahead with your slides. Thank you.
Thank you, Stefan, and thank you, Cecile, for inviting me to be part of this. So as Stefan mentioned, I'm going to talk about some of the work we've been doing on using such data to model COVID in South Africa. So most of my work focuses on digital epidemiology, and basically what that means is that I look at how we can use data from non-traditional sources. This includes internet sources, remote sensing for public health purposes, specifically surveillance. So I want to know how we can use what people are putting on digital platforms to study the patterns of disease, injury, and health, and drivers of these patterns in specific populations. So I work with lots of different data streams. This includes text, images, video, biological data. And this data comes from a range of sources, search engines, social media being some of them, mobile applications, crowdsourcing, etc. I'm going to focus specifically on search data for this talk, and there's so many different uses for search data, especially in the African context. So some of the earlier work that we did during the pandemic was look at what people were searching for. So what kinds of information were people lacking across the continent? So we looked at 21 English-speaking countries to see, has the information that people are seeking changed over time? And so when you had, at the beginning, when there was a lot of conversation around the need for testing, there were people asking questions about how to get tested, where to get information for testing, did they have to pay for their own test? So those are just examples of ways that we can use this data. For this particular talk, I'm focusing on how we can use it for disease modeling. So a brief background on the state in South Africa. As of October 12th, South Africa had reported about 693,000 COVID cases. They've had more than 4 million tests conducted and over 624,000 recoveries. And using digital data in this context means we have to think about the specific cultural context in South Africa. We can't just assume that what we've done in the US, for example, will work in South Africa. So we have to think about how do we bring in the cultural influences in South Africa to include that into a model so we can build better models for estimating the spread of infectious diseases, in this case, COVID. So we started off with general questions. So these are things that you'll see anywhere, not just in South Africa. So all kinds of questions are people asking about COVID. So things like, what are the symptoms of COVID, symptoms of flu, but also specific symptoms that have been noted for COVID. So things like cough, headache, shortness of breath, fatigue, vomiting. We looked at that data. And then we also looked at other ways in which people search for COVID. So coronavirus, Kagoro, how things like COVID-19 also specifically. And then home remedies, which I think this is where context really comes in. So we sourced these from colleagues in South Africa. So we asked them, what have people been talking about in terms of home treatments? And ginger tea is an example that kept coming up. Eucalyptus oil is another one. And this changes over time. So there are times when people will talk a lot more about ginger tea, and then there are times when they'll talk more about eucalyptus oil. And this is all very important for the models that we're trying to develop. When you look at the provinces, so there are 9 provinces in South Africa, there are very significant differences in the different provinces. So yeah, we have 2 provinces, and I'm going to present examples for these 2 provinces only, since we don't have time to go into all 9 provinces. And then on one side, you have all the terms, all the phrases that we looked at. So zinc is one that is very highly correlated with COVID trends. So you have the correlations on one side going from around negative 0.5 to over 0. Almost close to 1, so 0.9 in some cases. So you have zinc being very highly correlated. You have things like loss of smell being highly correlated with COVID cases. So those are searches for those terms. You have searches for COVID symptoms being consistently correlated across most of the provinces. And so because there's these very significant differences across the provinces, it was important for us to fit models for each of the provinces. When you look across the 9 provinces, there are search terms that keep popping up. So things like COVID symptoms, shortness of breath, eucalyptus oil repeated multiple times, zinc, loss of smell, runny nose. So these are terms that seem to be highly correlated with COVID trends. So these are things that people are searching for over time. We use the LASSO model. So our interest is doing very simple regression. And so yeah, our YT represents COVID cases. XIT represents Google searches. So we have multiple search terms and we only want the ones that are most significant. So our model in this case is doing two things. One, it's allowing us to select the most significant terms, and then it's also allowing us to fit a regression model with multiple variables. So the terms that are not significant in the model basically have coefficients that are 0, and they basically get dropped out of the models. So this again is the first province that I showed you before, and results were significantly different across the different provinces, as you see for the two examples that I'm showing you. So on the x-axis, we had proportion of positive cases. So instead of focusing on the raw cases, which we did look at, we wanted to look at proportion of positive cases because testing changed over time. So we wanted to just look at how many cases were actually being reported as positive from all the cases that were being tested. And then we have our model estimates on the y-axis. And then you have our confidence intervals around our estimates. You can see that a lot of the points that we're estimating do fall within our confidence range. And then on the right side, you have two lines. So one is the model and the other is the cases. And you can, so the long black line that you see that indicates where we stop the model fit. So we fit the model using data from when we had the initial case reported in South Africa up to that time point where you have the black line. And then right after that, we start doing one step ahead predictions. One thing that I think is interesting to note is that a model peak happens before the cases. And one possible reason for this could be that people were seeing symptoms and searching for that information online, but then they don't get tested until later. So this is the other province. You can compare the two. Again, on one side, we have model estimates and proportion of positive cases and confidence intervals around those estimates. On the other side, we have the trend over time. So we have the model and we have the cases. You can see this is actually very different in terms of predictions after the model has been fitted. Also, we don't really see that delay in the peak. So it's not very consistent from province to province, which is why we'll feed in different models for different provinces. And for some provinces, we have very good fit in terms of if you look at how the model tracks the cases, while in other provinces, that's not the case, especially when we start predicting. So these are things that we're investigating a bit further. So some of the reasons why you can see differences in provinces include things like internet access. So how many people actually have access to Google, how many people have the time to spend looking for things online. Demographics could also be a factor, and also COVID burden. So provinces where you have a high burden, people might be paying more attention than in provinces where you have a lower burden. Another thing that we're trying to do is do a real-time assessment of the models that we've developed so that we can have better models for each of the provinces, and also just see how useful this data is in South Africa and other countries in Africa. I want to acknowledge all the contributors in this project, especially Brooke Nichols, who's in this project and doing amazing work supporting COVID response in South Africa. So thank you all for listening.
Thank you very much, Elaine. Fantastic talk. Again, for the audience, please, if you have questions, use the Q&A box at the bottom of your Zoom window. We proceed now right away to the next speaker. Dr. Nirmal Ravi. Dr. Ravi has a background in biomedical engineering and primary care. Dr. Ravi started his professional career as a biomedical engineer, designing wireless ECG monitoring systems for resource-poor settings. He went on to do a Ph.D. in tissue engineering and MD from the University of Kentucky. He has lived in several African countries over the past 13 years, working on several diseases. Dr. Ravi joined eHealth Africa in 2016, where he is currently the Director for Medical and Scientific Affairs and the Chief Innovation Officer for their clinics. He leads a portfolio that includes laboratory, diagnostics, electronic health records, clinical research, technology, adoption, and community health program. Okay, with this, please, Ravi, go ahead with your talk.
Thank you, Stefan, for the kind introduction, and thanks NIH for giving us the opportunity to present. So I will talk about our response to COVID-19 in Nigeria. eHealth Africa is a nonprofit that has been working in Nigeria for the past 10 years. And then the last 2 years, we have also started delivering direct healthcare through a subsidiary called EHA Clinics. So I will talk about the different products and services that eHealth Africa is offering to assist the Nigeria CDC in monitoring and responding to the COVID-19 outbreak. These are some of the services that I will touch on. We have a logistics management product that Nigeria CDC is using to track commodities for the response. We have developed an automated symptom screening tool. We're assisting in interoperability of lab testing data through a lab information management system. And finally, we are assisting in sample collection as well as PCR testing for COVID-19. So I will start with the data and logistics support that we provide. The first tool that I will demonstrate is an interactive voice response system for symptom screening. This is an automated screening for quarantined individuals, which is especially useful currently in Nigeria as the country opens up to international passengers. So the mandate is that every passenger that's coming from abroad to Nigeria, and a lot of them are Nigerians that are living abroad coming back home, would need a negative PCR test to board a flight. But after arriving in Nigeria between 7 and 14 days, they need a negative, they need a PCR test results. And between those 14 days, they need daily follow-up as part of quarantine. The tool allows the user for bulk import of persons of interest records. So just from the flight manifest, the tool can import in passenger data and then can automatically follow up. The good thing is, or the advantage is, it replaces the manual process, which you can imagine can be very time intensive. Following up on thousands of passengers, hundreds of them every day, would be a manual intensive process because the vast majority of them would be asymptomatic. So what the tool allows you is to focus human resource just on persons who need additional attention because they screen positive on the symptoms. There's a dashboard that allows an overview of the statistics as well as any real-time alert that can go to surveillance officers. The system is interoperable with the National Digital Surveillance Tool, which is SORMAS. Alerts can be sent from the symptom screening tool directly to SORMAS, which can then be followed up with surveillance or by surveillance officers. The system can be easily modified for any workflow, and the responses and questions can be recorded in any language. We use an off-the-shelf tool to develop this particular screening tool, so it's customizable to the user needs. I will demonstrate the tool here.
Hello, this is an automated call from the COVID-19 response team at the Nigerian Center for Disease Control. We are following up on your health status. I will be asking a few questions and it is important to respond. Please verify that this is you.
Douglas Moran.
If this is you, press 1 for yes, 2 for no, or 3 if this is a wrong number. This is day
8 of 14.
Do you have a fever? Press 1 for yes and 2 for no. Do you have a cough? Press.
So that gives you an idea of how the tool works. Any person who answers positive for one of the screening questions is then tagged and would be visible on the dashboard as you see on the screen. So this gives you an overview every day, how many people have been called, how many are responding, how many dropped calls, how many failed calls, and then how many people will need follow-up. So far, the system has made about 69,000 calls for about 10,000 arrivals, out of which about 1,500 people screened positive on the questionnaire. On the dashboard, you can also see on a daily basis how many patients are screening positive on the calls, and these can then be passed on to surveillance officers for follow-up. The next tool that I will demonstrate or briefly talk about is the commodity tracking tool called LOMIS. That's Logistics Management and Information System. For a large response like COVID, you can imagine there are millions of items that are test commodities, personal protective equipment that are coming in at a federal level and then are distributed to the states. Currently, the tracking for this is manual, with reports being generated manually and sent to the central monitoring station. We have provided an automated system again that keeps track of inventory, real-time stock levels, utilizations, and expirations. So things that are first in or first out to prevent expiration of items on hold. We have recorded about 1.6 million items so far with this tracking system. Again, this has a dashboard that shows you how many items are received for each of the different categories, how many are outgoing, and how much stock is being held. I will now move on to the actual sample collection as well as testing that is done by EHA clinics in 2 locations in Nigeria. These are our sample collection and lab. From our test data, we have tested about 12,000 samples. The data on screen shows only about 8,000 samples. To put this in context, Nigeria so far has tested about 500,000 samples in comparison with South Africa that previously one of our presenters showed about 4.4 million. So much lower testing rate. The test positivity rate is about 10%, about 60,000 of those 500,000 samples have tested positive so far. And this is just Nigeria aggregate data. The data that I'm presenting only applies to 2 states or federal capital territories, so Kano and Abuja. As you can see from our data, about 8,000 samples tested, we only have seen a test positive rate of about 3%. In comparison to about 10% nationwide in Nigeria. You can also see the timeline. Testing started late April. In May, already reached a peak in about September, and the numbers are now starting to go down for both total tests as well as positive. This is the timeline for the percentage positive cases. You can see that early on in the epidemic, around June, May, we also saw about 10% test positive rate, but this has now tapered down to less than 3% at the moment. We did some statistical tests for associations between symptoms as well as tests. The symptoms and criteria on screen are taken directly from the Nigeria case investigation form. So for every sample collected, we collect certain symptoms as well as case definitions to give an indication as to the association. You can see most of these have shown positive association. This is the breakdown by gender. Total samples collected about 70% male, although when you look at the positive test, about 74% are male. This is the breakdown by age group. You can see over the time course, there has not been much change as far as the percentage of different age groups. Most of our tests come from patients who are between 25 and 45 years of age. So that group accounts for about 50% of all our samples. Although when you look at the positive tests, you can see that the positive tests are slightly skewed towards the older age group, that's 36 to 55 plus. We are providing passenger screening services with PCR tests, like I mentioned before. So far, we have tested passengers from about 95 different countries. The top 5 countries for incoming passengers to Nigeria are UK, India, Lebanon, China, and the US. Interestingly, the top 5 countries that are recording positive cases from among the passengers are Russia, India, France, Kenya, and China. The test positive rate that we see overall in the incoming passengers is less than 1% compared to about 3% that we see in the general population. With that, I want to thank you for some of my colleagues for providing some of the data analysis as well as the slides. And thank you for listening.
Thanks so much, Ravi. Very nice work. Again, questions, please, in the Q&A box. I mean, it will be interesting. I'm sure there are many questions here, but for the sake of time, we move on to the last speaker, which Frank Kagoro. Frank is a research physician for the Epidemiology Department at Viboud Oxford Tropical Medicine Research Unit, MORU, and he's currently doing his PhD at the University of Cape Town. His research focuses on tools for surveillance and mapping of infectious diseases and drug resistance. Frank holds a Doctor of Medicine from Tanzania, a Diploma in Healthcare Management in Tropical Countries from the Swiss Tropical and Public Health Institute, and a Master of Science in International Health and Tropical Medicine from the University of Oxford. With this, please go ahead, Frank, with your talk. Thank you.
Yes, so I'd like to share with you on user-centered dashboards for COVID-19 trends in Africa. And I think if other members of the webinar now would appreciate is we have a lot of information that COVID-19 has offered us and an unmeasurable number of ways we can measure the disease and track its trends. But the question comes to how much of this go to the users. And these are people who are on the front line of the COVID response. So my work actually centers on how do we translate some of this knowledge and measurements to the public. Next, please. And so the beginning of the pandemic, actually Africa, we had a bit of a pause before the storm. And everywhere COVID started in January, but in Africa, somewhere around February, that's when we started experiencing cases in sub-Saharan Africa countries towards the end of February. And now Africa actually has 4.2% of the global cases. And if you compare that to the 15.7% of the population of what African population is to the world, we might say somehow we are spared. But then with the innumerous amount of knowledge, the challenge that presented in the beginning was there was lack of user-friendly and adaptive decision-making tools. So we did a study which was more qualitative to speak to the frontline health workers and what they would like to have so that they can be able to respond to COVID-19. Next. So we decided to create up-to-date user-friendly COVID-19 visualizations. And this was just to support these responding teams. Next. So one is what we called it COVID-Dash. And what COVID-Dash does is, the aim is to develop and share adaptive and interface that shows the burden of COVID-19 in Africa. We can appreciate now there's a lot of dashboards that have been put forward with the Johns Hopkins dashboard leading the way, WHO and the other organizations. However, in the beginning of the outbreak, most of the dashboards focused on showing the burden at scientific level, and a few of people who are in the front line of response. So here we are talking about, if we are talking about surveillance officers, these are people who have basic education, who go to look for COVID-19 cases for testing. Or if it's district teams, these are people who are trained to probably second high school level or bachelors who don't have understanding of modeling. So the aim was to simplify so that we can increase understanding and also see the information that is being published. So on the right side of the slides, you'll see that is the framework that we try to implement. And below are the visualization that show of how this dashboard and the final product looks like. Next. And if you can help me to play, if you can click play down at the bottom. Yes. So this is COVID-Dash. What COVID-Dash is, it's a mobile-friendly platform, and it will show you where Africa world publications, burden, how the burden looks like. It will give you summaries, thoughts, table, and maps. It will give you cases of different places in Africa, top 10 cases and deaths. It will give you epi curves for different countries and select inputs where you can choose whether you want to see the whole of Africa or only just countries. It will also show you a table of different countries and where they fall with different case fatality rates. It also gives you a map where you can zoom in, show you cases, deaths, and you can weigh them according by population to see where where we are most affected by COVID. And you'll see South Africa, Egypt, and Algeria, which is so far currently show most of the cases. So this is part of what we thought could be user-friendly to healthcare workers and people who are in the front line of COVID response. So all the models and work that we do, how best we can sort of tailor it to the end user, and they can be able to change and see at different times how things work. They can also see global statistics to just know a global summary of where we are at. At the moment when we're recording this, we're still not past 1 million deaths. And the most important part of COVID-Dash, it also gives you published information of COVID-19 in Africa. So this is a living systematic review that shows you what is the information that is being collected, it's being published for COVID-19. And you'll see how studies evolved over time until we have more than 1,000 of publications now on COVID-19. You can go and look for every paper that has been published. But another interesting part is where you'll be able to evaluate any study and say which topic does it fall. And when you click submit, we receive this review, and it goes back into the table where someone, if they want to read a paper, like here, they can select if they want to read surveillance, health system, or treatment paper. So it helps them to use shorter time instead of going to work to look for more information anywhere. They can just get all of it just on their palm. Next. Next slide. Thank you. So, and the other dashboard that we're involved in, this is part of the national COVID-19 EPI model. So this is not the whole of Africa, this is more of South Africa. And this was to translate the outputs of the COVID-19 projection model to a user-friendly platform that is interactive, and it can be used up to the district level. On the left bottom side, you'll see that's the framework. So people can, health workers can interact with, and the policymakers can interact with this dashboard to see the trends, but also they can download the reports. On the same framework on the right side, you'll see that it also responds to frequently asked questions. Next. So if you can play, just a little a sneak peek on the this dashboard, which is actually tailored for people who are working in the provinces and the districts. So first, it'll have a disclaimer to tell them what projections are about and what are the data usage of this model. It has projections which are cases, hospitalizations, and the deaths. So all the models have already been run, but the output that is given from the model, this is the way we thought we could present it for people to understand where we are going. They can select different cases, whether severe or symptomatic, and see how they're projected over time. they can open a table, they can also project it on a map, and this is for all the 52 districts of South Africa. And also they can compare between different districts. So in this way, like here you can see we are selecting different districts, and one can compare also between different provinces. And these are in cases, hospitalization, and also projected deaths. And what it also gives you is you can go back to time, or you can go ahead to the future of the projections to see what we project to see in the future with the trends of COVID-19 in South Africa. It also gives you a resources page, which you can go and read more about the model, who are the collaborators. It gives you reports. Also the frequently asked questions, where most of the questions which ask about model and the modeling can also be found here. Next. So a good thing with the strengths that have come from this work. Next. So the strength is COVID now is currently being used by clinicians for COVID-19 trends. We get a lot of feedback of what we can do to improve. It is low maintenance because it auto updates itself. It uses R and R-Shiny and data mining tools. And for the South African dashboard, it's being used by district teams to respond on COVID-19. And the software itself, it's been very useful because all new data can be put in and the projections can show. So it also now runs under low maintenance. Also it gives PDF reports and the Excels. So the only limitations that come out of this work is the challenge is all of these models require a lot of interpretation to be able to explain to people of what all this data that has been comes from all our analysis mean. One challenge is we can be able to map COVID-19, but if we don't liaise with, we don't sieve this information for the public, we fall into a lot of challenges. So we are limited on who to reach and how to reach them. And also we are constrained with time of how to respond. So such platforms that are user-centered can be very useful. And so there's still a lot of opportunities. A lot of these tools are available online and using open source coding. We can work globally and work with a lot of people. And so this is more like, with this kind of work, we can foster collaboration that are global, because some of the team are people who are based elsewhere in the world, but we are being able to tailor things for African scientists and people who are responding. So with that, I would like to say thank you. Next slide. And apologies again for technical glitches. So one of the first challenges working also in our context is technology. And I'm sorry you experienced it from my presentation. Thank you.
We had very nice talks so far, so I think this will give us good material for discussion. My co-moderator, Cecile, will actually take over now. Cecile, are you online? Can you lead the question answering session?
Yes, of course. So we had quite a few questions, and we'll go through as many as possible. A lot of those questions relate to the data that have been used in the different models. So we'll go through that. So starting with Ali and the IHME model, there's a question about a serosurvey, and there are too few. There are some, one has been cited for Nairobi showing an 8.5% prevalence in June. I've heard of some in South Africa that show prevalence as high as 30% in rural areas. And so those tend to be higher estimates than what the prediction of the IHME model would portray. So Ali, I don't know if you have any thoughts on how, when you get more of the survey, you could include them in your model.
We include all seropositive surveys. So the question said there is one that has 8%. I can't recall exactly, but some of them, how they do the testing, we exclude them because the quality of testing or the type of testing. But in Africa, the question says it's projected to be 40. We haven't seen 40% in Africa. We don't see it in South Africa. The highest we see right now in the US is New Jersey 25, and Ecuador, there are surveys at 45. So I don't think any country in Africa has 40%, even 20%, much lower than that, over.
Yeah. So just to follow up on that a bit, probably, I mean, there is supposedly a lot of heterogeneity in infection rate within a country. I mean, we see that in the US, right? And so presumably that's also the case within each of those countries in Africa. How do you handle that in your model?
So if we have a locality one, we adjust it, we take it and we adjust for the population size and include it in the rest. If it is, the key question for us to keep it or not to keep it is what type of testing they did. We use our labs here, we check with them if that's a valid methodology. So there are surveys in the United States and California that we didn't include, for example.
Great. Okay, more questions for you. So you have interesting data on mask wearing in your model. How is that measured?
So mask wearing and mobility is done by Google surveys, and they have about 1 million every week in every country in the world except like North Korea and a couple of places. But for Africa, which is a very good point to keep in mind, that that's an overestimate of mask in reality, because the more affluent are more likely to be on these smartphones. And mobility is, of course, underestimated because the more affluent are more likely to respond and they're more likely to stay at home. But the source is Google, and 1 million every week.
Yeah, I mean, would you be thinking about potentially doing more representative survey just to try to titrate the Google data?
Not IHME doesn't do that, but IHME takes surveys that have been done in other locations and calibrate. So we have switched, for example, in the United States to another source because all the other surveys independently, random surveys, were showing the numbers are different. So we switched to that. We keep an eye on other surveys when they're available at the national level. We'd like to use Google, but we adjust the estimates if that's available.
So more general question about data in Africa and how that collected. So we understand that you're not generating data yourself, you're collecting everything that's available. But to rephrase that question a little bit, can you point at really key data gaps in some countries or types of data, and then maybe alert the community that your estimates are perhaps not as viable in those places with less data?
It's very good question. Yes, the quality of data varies from location, and in certain, I mean, to our surprise at IHME, that in places, for example, in Africa, some types of data is way better than everywhere else, depending what you're collecting and what you're doing. So yes, we have a lot of gaps in Africa in data and vital registration and testing and mortality reporting. We know there'll be excess mortality. We have no idea. We have few locations that we are very confident about in Africa. So there is a lot to be done, but in one of the questions, and I'm diverting a little bit, but it's still within the same, that I don't believe that people said they don't believe the data in Africa. There is 2 points we need to keep in mind, epidemiologists. The number itself, what's the prevalence of people who are being tested, who are positive for COVID-19 in a country, and there is a trend for that. And then if the quality of data is bad, but it's done exactly the same way at every time, then the trend is more likely to be correct than that. So we need to keep that in mind. All trends in Africa are showing a decline. So I have no reason not to believe there is a decline going on in Africa. But yes, the number is an underestimate, of course, due to data quality and gaps in data. Over.
Great, so we'll let you rest for just a second and move on to questions for Agnes. So another question about data quality, I suppose, but can we really trust the Ugandan metrics on COVID cases and deaths? What is your opinion, Agnes?
Yes, I like the previous speaker has mentioned, data is always data. The quality might be compromisable at some point, but in general, the epidemic shows that there's a decline in some countries or in the African continent. And I think that on the Ugandan side, the government has been very keen to increase testing. We've seen the tests per 1,000, increasing from 0.01 to about 12 per 1,000 right now. So I guess with the prevalence we're seeing and the metrics, I think that we believe the data, and with the decentralized testing and the ongoing quality control measures in the country to ensure that what is reported is correct, I think that it's the data is as is, and it might have its gaps, but I think there's a bigger part of it that is reliable.
So another question for you, Agnes, about it's more of a methodological question. So what tool did you use for your sentiment analysis and the values of the variable trust, mistrust, etc. that we saw on your graph? What's that based on? Okay, so the analysis is done using Python and R and the different algorithms, and the values would show if it's a negative sentiment, it's any value that's negative, that is negative or less than 0 is a negative sentiment, and the positives or all those above 1, above 0 are positive sentiments. But we did that using Python. Great. One more methodological question. How did you identify Twitter influences? Is that like a network model? Or? Yes, it's what the network analysis, and we largely relied on the tweets and the retweets. And if you conduct that analysis and you find that there are people who have, there's some kind of centrality around them, you find that the person is always tagged in a tweet or a retweet, we then used how many nodes were, how big, how close that person was, or how big their node was in the network analysis, and then called them influencers. But this is still ongoing work. Okay, great. And just to reassure you, can you confirm that when you get data from Twitter, it is anonymized? Yes. Very good. Okay, so I am told that we can resume the talk session with our last speaker, and then if there's any time, we'll take a few more questions at the very end. Thanks. Over. So we still have a few questions, but you can ask those in the breakout sessions, and we'll give you some guidelines for that. But just to wrap up, it was a really good set of diverse talk describing both burden estimates, but also projections for COVID-19. And we touched on how difficult the data are, which is not a problem that's specific to Africa. Really everyone around the world is struggling with COVID-19 information, but that's also an opportunity to use novel data streams as we've seen, right? Including Google and Twitter, and also interesting tool to help with monitoring of suspected cases and returning travelers. And also the importance, as we saw in the last talk, of just visualizing those data and making them publicly available to the public and understandable as well. Great session. There's more opportunities for discussion in smaller groups where we can see all of the participants with the panelists. So first session on direct impact of COVID-19 with Ali and Elaine and myself. The second session on indirect impact. We've heard about HIV, but there's also lots of questions about impacts on childhood infections and vaccination. So that's with Agnes and Amit. And then another session on methods with Stefan, Ravi, and Frank. And I'll hand it over to Poulin, who will give us more guidelines on how exactly to reach those sessions. Over.
Fantastic. Thank you so much, Cecile, and thank you, Stefan. Fantastic moderators. Thank you. Special thanks to you, Frank, for just bouncing back and being able to give that talk in the midst of the technology challenges. I'm based in South Africa, so I fully relate to the technology challenges. So thank you so much for still being able to present to us, and to every panelist who has shared their presentation, their wisdom, and their very interesting and timely discussions. We really appreciate you. Now, I would like at this point to invite panelists and moderators to go ahead into the breakaway rooms, get ready and set it up for the interactive sessions with the participants who would like to engage with you further on the 3 topics that we will highlight. And for all the participants, I invite you to just stay in one more moment to continue a bit of conversation with you about how to join that interactive post-webinar program. But first, and in a chat, we're about to put in a link, and it's also on the screen, and that's an exit poll. We would like you to please click through it and give us feedback very quickly, 20 seconds of your time. We're actually going to give you some time to do it right here. Please click on the link and give us some feedback about today's session and what has worked really well for you and what hasn't worked. We really appreciate your feedback. We appreciate your attention today. Thank you for joining us. And we're going to give you a couple of seconds to fill the survey. So click on the link and you should be able to get a couple of questions that would like to invite you to engage with just for 20 seconds. Great. So we do have another upcoming session in the next week. So please do check out the screen. We have placed the title of the upcoming session in this series. So the program is going to be on health metrics. That's also going to happen on the 21st of October on Wednesday. Please do come and visit us and spend time with us. Same time, same place, and go to Kistorm and you will get the link to the webinar and the interactive session. Thank you so much. Now, are you eager on how to get into the interactive session, which is a really close interaction with the panelists today? All of those questions that we didn't manage to answer on the webinar, you can ask them directly to the panelists in an intimate setup where it's just the panelists and yourselves, and you can engage and you can direct the conversations however way you would like to. So in order to get there, the same link that you used to get here today is the same link that's going to lead you to the interactive session. So when you do leave this room and return to your browser, it would have refreshed with several virtual post-it notes on your screen that will appear on this page as you scroll down, and one for each of the 3 breakaway sessions that we'll have. The 4th breakaway session will be just for the technical assistance. So each of the breakaway rooms has its own Zoom room. You will click and on join the Zoom to enter the interactive session, and that will last about 30 minutes. You might find yourself really interested in one topic and you can stay there for the whole time. Otherwise, you're welcome to visit the rest of the Zoom rooms by going to the same link. Remember that if you need help at all or get lost or get bumped out of a session or lose your way or just find the team help on the Kistorm page button, and we'll give you the help that you need to get to the breakaway session. With that, I just want to say thank you to the moderators who have done a fantastic job today, and our panelists, and most of all to all of you for being with us until this far. We hope to see you again shortly in a few moments in those interactive sessions, and next week at the State of Data Science session on health metrics. Thank you so much. We'll see you in the breakaway rooms. Thank you.